So we'll move right on, and we will be hearing about the implications of seasonal and climate factors on the risk of measles. And Jessica Metcalf will be speaking to us on that. Let's welcome her with a clap, please.
Hi. So we're surprisingly seasonal animals. The way children are born all around the world, even today, and in New York from Madagascar, depends on the time of year. So more children are born in late spring in Madagascar. We're also seasonal in our behavior, and we can see the footprint of this in the transmission of directly transmitted infections, where transmission tends to be low at times of year when children are not in school. We also tend to deliver our healthcare in seasonal ways. Every row on this plot is a district in Madagascar showing vaccination coverage, and the rows light up during weeks in April and October during Mother-Child Health Weeks, which happen twice a year. I'm going to talk today about measles. So measles, because of its potentially very high case fatality rate, and because we have a completely immunizing, very inexpensive vaccine, has been called a best buy in public health. Every WHO region has a measles elimination goal, as depicted by this nice Sophie Blackwell illustration. Every part of this seasonal clockwork will shape measles dynamics. Measles is a completely immunizing infection, so the only source of new susceptible individuals, the S, is births, which are seasonal. Transition from susceptibility to infectiousness is driven by transmission, and measles transmission is seasonal all over the world, often driven by school terms. In Madagascar, measles incidence is happily very low, but we can see the signature of school terms in rubella, which will have similar drivers, there on the left. And all of this will interact with seasonality in healthcare. Madagascar is subject to devastating cyclones, which tend to disrupt access to many parts of the country. These occur around Christmas, and the timing of those health weeks is partly determined by the cyclone season. Because of the way this timing of healthcare plays out, children will move in and out of susceptibility over the course of the year. And since the age of children affects the risky outcomes associated with measles, we need to understand this. And so what we need to do is build mathematical and demographic models that can unpack how susceptibility plays out over the course of the year, given all these different drivers. And to show you how that works, so we can just plot out seasonal births on the left-hand side there, fluctuating according to the data I showed you earlier, and then we can track children forward over age as they age. And I have a very bad feeling about where this slide's going to go. Oh, well, the colors are all wrong. But what you should be seeing is that as children born in June will be the youngest children to be eligible for the April vaccination week. So eligibility window goes from 8 months to 11 months. And so at around that age, vaccination will occur. Children born early in the year will be older when they reach that window of eligibility. Wow, this is very hard to interpret. And what you should have seen on this plot was that there's a relatively straightforward fix. There's a window of children would come through susceptible just because of the way that timing of those vaccination weeks was working out and because of the age eligibility. But a simple fix is to increase the upper age of eligibility. So it's a low-cost change to the program. Although ultimately what we want to do is strengthen routine vaccination, demographic thinking can show us both this potential issue that results from the demographic drivers and the seasonal drivers, and can point to a particular solution. So with funding from the Wellcome Trust, we've been working to bring more detail to this picture. So we've been collating data across urban and rural settings on more nuanced opportunities for vaccination over the course of the year. This is work by Ketli Mensah. And we've been integrating various data sources from mobile phone call data records, which give us windows onto people's mobility, through to looking at paper records held at the health centres across the country. And this shows one lot classified by the month of birth of the children. So you can see that playing out here. And this gives us an opportunity both to digitize these important data sources, but also to interact with people who are working at this front line of measles vaccination and healthcare in Madagascar. And of course, it's very hard to anticipate the outcomes of natural disasters, as Duncan was telling us. We understand the natural history of measles so well, we can start to plan for the future. And the problem, of course, is that the future is changing. So the frequency and timing of cyclones might change, but the next set of questions will be to start working towards this. So I'd like to thank all my co-authors, many of whom are here, and the Wellcome Trust who funded some of this work.
Thank you, Jessica.